Okay, I'm going to present a case of endovascular repair of thrombus-laden pseudoaneurysm, which is a rare case of carotid artery presenting as recurrent TIAs. And this is a story of a 78-year gentleman who had recurrent TIA in the MCA territory. He had bypass surgery 6 years back and also had a left carotid endarterectomy. And they had done a patch repair using a Dacron graft. And he was hypertensive, diabetic, and had a very severe chronic obstructive airway disease. This is the pseudoaneurysm, which has actually arisen at the point where the Dacron was sewed after endarterectomy to the carotid wall. And this is the CT scan, which shows the aneurysm. And when we did a duplex scan, we found that there was a very narrow lumen left in the carotid artery. And if you see, there was a lot of thrombus in the, just where you see the blood flow, a lot of free-floating thrombus in the internal carotid artery. Now this is the cross-sectional image in a duplex scan where we see a free-floating thrombus. And obviously this patient was very high risk. The surgeons did not want to take this up for surgery because it was extending into the neck, almost up to the base of skull, and they had a problem with the distal control. And this loose thrombus was very likely to cause a stroke during the surgery. We had a lot of interventional challenges, and these were mainly an acute angle takeoff of the left common carotid artery from the aorta, a lot of loose thrombus in the pseudoaneurysm, and so we still decided to do it, and to do it with a distal protection device. And we had a lot of devices in our mind. The first one was MoMA, but we didn't have it at that point of time. The other one was a PercuSurge, and other ones of distal filters like EPI, AngioGuard, or Spider, and also the choice of stent. So this is how we hooked the left common carotid artery. We got a catheter into the origin, then got a wire into the external carotid artery, got a sheath up into the common carotid artery before the aneurysm. And this is a shot from the sheath. Then we used a Spider filter because it had the lowest crossing profile, and it allowed the use of coronary wires, which are the most gentle wires in our hand. And it has the lowest incidence of spars, and the pore size was 100 microns, although we have better filters in terms of pore sizes. So then we passed a Spider device, and we opened the filter. So then we passed a Spider device and we opened the filter. This is the open filter beyond the aneurysm and the thrombus. Till that time there was no TIA or stroke. And once we had the filter in place, we put a barred fluency stent graft across this pseudoaneurysm. This is the stent graft being positioned there. And then we opened the stent graft and deployed it. And then we saw that while we did this, even in that time, we trapped thrombus in the filter. And we were lucky that we had the filter, and the thromboembolism happened after we had put the filter. After we did this, we did an aspiration and cleaned that area up, and then took out the filter. So this is the completion intracerebral angiogram, which shows that the patient was fine on the table. There was no distal embolism in any of these branches, and the patient was fine. This is a follow-up CT scan showing good positioning of the stent. And we discharged the patient on the third day on aspirin, clopidogrel, low molecular weight heparin, statins, and ACE inhibitors. In a follow-up, there was no TIA or stroke, and we followed this patient now for more than 3 years. So in conclusion, this was a successful endovascular repair of a thrombus-laden pseudoaneurysm of the left common carotid artery using a spiral and a distal protection device and a fluency graft. Subsequently, we have done 5 more cases of similar types or different types of pseudoaneurysms or aneurysms with thrombus with the stent graft. Thank you very much.
Thank you. We have 2 minutes for questions, please.
What is the what is the general follow-up of stent grafts in carotid artery? What's the percentage occlusion and thrombosis in these grafts?
I sort of searched the literature. I mean, as a primary therapy, it's not indicated. Even in deeply ulcerated plaques, it's not indicated that we put in a stent graft primarily. But in situations like this, where we have to have a bailout situation, there's high risk for surgery, and we have a thrombus, there are reports of putting in stent grafts. We have done 6 patients. None of our patients had a stroke or a thrombus, but we keep them on low molecular weight heparin and aspirin and clopidogrel, and sometimes also on oral anticoagulation for a few weeks. In general, I don't know what is the follow-up on the literature for primary stent graft deployment in the carotids. Maybe Dr. Henry or Dr. Buckley would be a better person to answer this.
I would have only anecdotal experience with it. We've used it a couple of times, and the times that we've used it have been, it's been successful, and to my knowledge, they've remained patent, though neither of them were my patients, they were patients of my partners. However, the previously operated on carotid with a patch, vein patch even more so than the Dacron patch, once they become pseudoaneurysmal, and they've been in there for a while, several years, they frequently are loaded with very friable embolic material. And operating on those has resulted in bad outcomes in a number of instances because you cannot control the debris that's inside the vessel while you're getting exposed. And because it's been previously operated on, the exposure is difficult and you have to mobilize the vessel a little bit higher, a little bit lower. And so where I've seen really bad outcomes from carotid, surgical carotid intervention, have been on just these kind of redo cases where the patch has been on for a long time, became aneurysmal, and then somebody goes in and intervenes on it, and they manipulate the vessel too much while they're dissecting it out, and that stuff showers up into the head with bad outcome. I think it's one of the good indications for filter or MoMA device and an endovascular solution rather than a surgical solution.
Thank you very much indeed. That was our